Welcome to the post-lunch session. This session is on heart failure with improving ejection fraction. The speaker is Dr. Satish Govind. Doesn't need any introduction. So Satish, you may take over.
Good afternoon to you all. I had a nice discussion about fish and Calcutta, so I'm still fresh about that. But that's more simple, and I think this is a little more Very true. So there was a time in life when things were simple. We had a heart failure with just systolic, diastolic, and then it started to change, and just like aortic stenosis, which was very simple. So these are the newer categories, and there are a lot of debates and contentious issues. So I will sort of focus on this area here. So some of the slides are familiar, but I have my own perspective, the way I look at it. So you have this ESC guidelines, and you have these three categories, and there is this one particular statement in the ESC which they say that they have changed the term and discarded this mid-range, and it is mildly reduced. That is number one. And what is of interest is they sort of look at this number of 50%. So this is the improved ejection fraction. They have a cutoff of 50%. And they also use this word recovered ejection fraction. So three important points from this. Now, when you look at the ACC guidelines, which came up this year, they have a special place for improved ejection fraction, and they have a cutoff of 40%. And this is the difference between the two. And then you have this mid-range, which we have already sort of listened to it. So you have this combination of both reduced and sort of preserved ejection. So this is where a lot of issues are there, where you have a combined one. So just looking at this, sometimes the issues are like somebody, we'll sort of listen to how the ejection fraction can be variable. So somebody, let us say 45%, can have a extreme sort of variability. So if it is 35%, so then it goes into reduced ejection fraction. Then the things crop up like something like device and the CRT part of it. The ICD. So, and then if it is 55, so they go into preserved ejection fraction. So there's a lot of confusion about these numbers, and one can look at it from their own perspective. And again, this familiar slide. So this is again, watch this space. So things are going to change. So here you have this reduced ejection fraction, improved ejection fraction. So still there is no clear definition of what exactly is improved ejection fraction. And also there is this definition of recovered ejection fraction, which keeps coming up in the literature. So recovered, some of the literature sort of implies that it is something where it is normalized. So that means it is more than 50. So more likely, we might get a fresh sort of a categorization here below improved ejection fraction. Now, the main focus from my side is so looking at echo, so when to do in heart failure. So this is again 1C here as far as the ESC guidelines, and you have this diagnostic algorithm which we're all familiar. So, and then based on this EF, so EF is a key sort of number which keeps coming up, and you get sort of the separation of that entities over there. Now, when you look at the ACC guidelines, they are slightly sort of more elaborate. So here you have, all of them are, both of them are 1C here, and you have suspected or newly diagnosed, where TT plays a big role. So the focus is on cardiac structure and function. And then you are those patients who have had a significant clinical change or and who have received the GDMT and are being considered invasive. This is where 1C is. And then the focus again is measurement of EF, structural and valvular function. So this is how it is. The diagnostic algorithm is similar to the ESC. So now, echo, what to look for. So this is a slide I've taken for the stages of heart failure, but still sort of broadly encompasses what we should be looking at as far as echo is concerned. So again, looking at the functions here, the biventricular function, and then looking at ejection fraction, and then the first time you start to see strain sort of appearing in the guidelines, which is sort of given importance sort of in the table itself. And then you have these various structural changes and valve disease, and also looking at pressures. So broadly, this is how the approach should be when looking at echo. So further to divide it, how one can approach it. Broadly this will apply for most of the heart failure patients, but this is more specific for reduced and then the improved ejection fraction. So look at structural. That means looking at the chambers in terms of its size, thickness, and all those things. And then the abnormalities, the wall motion abnormality, any presence of thrombus, and then also to look at the LV shape and then the valves itself. Systolic, the focus is on ejection fraction. Ejection fraction can be 2D, 3D, and then again 2D enhanced, contrast enhanced 2D ejection fraction, and then the sub-measurement, stroke volume, cardiac output, and strain GLS, LV GLS is the one which gets priority, and of course the RV TAPSE validated should be used. Diastolic function, grading of the diastolic function, and then using these various parameters and looking at the LV filling pressure. And of course the last one is no heart failure patient can go from the echo room without the PA pressure. So just a few images of how the 3D is sort of lot of focus because the accuracy is much better. So 3D, if you have 3D, so use it. If the window is good, use it. And for 2D, in case if the window is not good and if it's very important in terms of taking decisions. So again here the contrast enhanced LV should be good enough. Now strain, so this is the very sort of simplistic slide, but it gives you a lot of sort of insight into how the mechanics work. So there is this GLS, so in a hypothetical way, if it starts to decline, you have this consistently going down, and then at this point when the GLS starts to go down, the circumferential fiber starts to sort of kick in and then tries to compensate. And at this point where this blue circle is, that's when things go wrong. That means the circumferential strain starts to decline and it crosses this line, and that's when the ejection fraction comes down. So at this point of time, ejection fraction can be very, very deceptive and very sort of deceiving. So all this time it will be sort of on the normal sort of a range, but it is strain which has provided insight, and that is where the importance is. So it's a little bit of a busy slide, but let me sort of take you one by one, and this is where the LVEF and GLS sort of where they actually stand. So one is looking at LV, so looking at the LV volume. So the EF looks at volumes, while the GLS looks at the muscle and the regional mechanics. So they are two different approaches. And the EF is used to classify the various categories, while the advantage of strain is looks at the subclinical early impairment. Predictive, its EF is a very very old friend, and it is a very good robust predictor of cardiac outcomes, while GLS has been shown to have good sort of prediction in all-cause mortality and also in risk stratification. Load, both of them have load sort of implications, but GLS is much better. In terms of reliability, so we have this problem which we already discussed, geometric assumptions in the LVEF, and then here the image quality. But I think both are sort of image quality dependent. The better the image quality, more robust will be the parameters. And then for EF, when you add 3D, it becomes slightly better. That has its own problem. And GLS has been pointed out by the various speakers on strain yesterday. The vendor and software space is very important to mention. Feasibility, where do we stand? So when it comes to the EF, it is about 70 to 80% sort of successful. But when it comes to GLS, it is about 91%. And the EF improves with the use of contrast agents. So if you do have this facility for contrast, use it. Pitfalls, again, underestimation of the LV volumes by 2D EF, and then this has got its out of plane motion. So when it comes to variability, this is where the issue is. So you have about a huge variability of around 8 to 10%, and then the inter-observer sort of variability sort of is high, but when it comes to 3D, it comes down, it's much better. And then the variation of strain, on the other hand, is about 5%. So that is where the real sort of plus points are. And correlation with CMR, you get to see the 2D is about 0.6, and then strain is about 0.7, and 3D is about 0.8. So this is where they sort of stand with each other. When it comes to following up patients, so the GLS really scores. So this is something which you should use regularly. So there's a lot of variation when it comes to 2D, and then the 3D is slightly better. So one important simple statement, so M mode should not be used for LVEF. Now just a brief look at a patient here. So this is a middle-aged male, hypertensive, no CAD, symptomatic, was put on GDMT, and typically, so how you sort of go about doing it is look at structural issues, wall motion abnormalities, thrombus, any thinning, scarring, aneurysm, and also to look at the size of the LVs and the size of the RV and the other chambers also, and then a brief look at the valves also. And then the pressures, so looking at the pressures, it's more grade 2 diastolic dysfunction, and then the systolic dysfunction is about EF is around 28%, and GLS is about 10%, and RVs, the free wall is somewhere around 20%. And this patient was put on GDMT and then comes back after, he was on follow-up, and this is an echo done after 5 to 6 months, much better, and you can see that the EF has improved to around 41%, and the GLS also has increased to around 14%, while the RV showed slight improvement. It really sort of remains. So there is something which happens to these patients where the ejection fraction improves. Now this is the other extreme. So the reduced ejection fraction, this is one patient which the other way, worst outcome. So you have a very bad RV, dilated, this is advanced heart failure patient, significant valvular disease, and pressures all over the place here. And when you put the strain, everything is really bad. So this is basically a transplant patient. So this is the other extreme of reduced ejection fraction. So now let's look at the literature. What does it say about improved ejection fraction? So this is a hypothetical model. So they have categorized it into elastic and the plastic regions. So this is using the parameters of stress and strain. So why do these patients, some of them don't improve, why some improve? So this is the sort of explanation where they have looked at this model. So as long as the patient is within this elastic region, there is the reversible damage can be sort of changed in terms of myocyte, in terms of the muscle itself, the myocardium. So as long as it is within the reversible sort of phase in terms of pressure and volume, they improve. But once it crosses this point where the top area is that irreversible damage, so that is a crucial point. So that's the tipping point. So this is where the recovery won't happen. Again, a busy slide here. So looking at the various sort of studies. So how the LV improvement in reduced ejection fractions, and how did they look at it? So let us sort of break it up. So you have the publications here starting from 2004 up to 2017, and then you have the definition of LVEF. So this is where a lot of problem has happened. That's why there is a lot of variability. And they also looked at the frequency, the amount of LVEF improvement, and then the characteristics. So let's look at the red line. So this is the peripartum cardiomyopathy using traditional medications. They had a EF of around 50%, and they had a remarkable improvement, almost around close to 50%. So what did they look at? The echo-wise, they looked at the LVIDD, looked at EF, and looked at LA diameter. Now another category of the peripartum cardiomyopathy, very high again, this is with beta blockers, again looking at LVIDs. So the LV measurement, the size is very important apart from the ejection fraction. Now, let us take the green line. So you have the recent onset cardiomyopathy. Again, the ejection fraction here is 50%. That was the cutoff. And then again, around 20+%, and then looking at the LVIDS. Now, this is the biggest sort of number, 4,400. And the frequency of LV improvement is surprisingly very low here. It's just 9%. And they had, apart from EF, they looked at the LV size. So there's a lot of variability. And if you look at this particular column, definition of LV improvement, you have the blue ones, they say increase in the LVF of 10%. Two studies looked at it. And then there's one study which is 45%. So there's a lot of variability here. Now, in terms of the cellular and molecular determinants of LV function, so there is LV dilation. So you have these various sort of treatment approaches. So beta blockers are the ones which show good sort of improvement in terms of LV, and then all these other sort of parameters, the genetic markers, and looking at the various issues. So the LV dilation is again a very, very big sort of a parameter. So just a few sort of studies where I am going to look at. So here looking at the outcomes. So looking at both reduced as well as persistent and the recovered, and the persistent ones. So they did 2 echoes 3 months apart and 1,000+ patients, and then 25% showed recovered ejection fraction here. And those with more than 20% had lower rates of adverse outcomes compared with between 10 to 20%. So the higher the EF improvement, better the patient sort of does well. And the short-term mortality, at least for 2 years, was pretty good. And this is again looking at the outcomes again. So this is the VALHEF trial. And here they looked at around 5,000 patients, again dilated LV, and they had lower odds of improvement. The more bigger the LV and lesser the likelihood of improvement. And the EF was associated with better survival compared with the persistently reduced EF. So again, the reduced ejection fraction had the improved ejection fraction as a stratum showed more favorable outcome here. And this is a meta-analysis. So again, look at the number here, 24 studies, but just 2,600 patients. So again, the numbers are just not there. There are multiple studies, but all small numbers, so we don't know how well the power calculation, most of them are exploratory sort of feasibility sort of studies. But that's the data which is available. So it's still a work in progress, this particular entity. So here the EF improved by 16%, and then again the LV sort of diameter somewhere around 64 millimeters. So this was the one. And so improved EF, lesser diameter, so had increased, they had lower risks of mortality. So recurrence. So what again the recurrence, the focus is on the LVIDD, and this is the EF. And again the frequency occurrence is anywhere from 20 to 40%. So this is the number where there is a recurrence happens here. So to conclude, so a few sort of statements looking at basically the literature. So you have this reduced ejection fraction. So you have these three pathways. So the ones who recover, as was told earlier, the peripartum, the fulminant myocarditis, Takotsubo. So these are the ones sort of they improve, and they, along with this, any females, non-ischemic cardiomyopathy, and then lesser the duration of heart failure. And if there is no initial remodeling, they sort of go into this category of heart failure with improved ejection fraction. And here the parameters to be followed up are the dilation and the EF here. Second is that if they have adverse sort of remodeling and the medication adherence is not there, and if the GLS continues to be low, so they go into reduced ejection fraction from here. And these are the normal, the recovered ones, so-called. So they are not truly sort of normal because they all have subclinical dysfunction. So there is a lot of debate about it. Some data is still coming in. So these are the patients where the TT is normal, but again, they may have a problem later. So it is very important that we continue with the echo monitoring. So how often do we do it? So here this is still unknown. So how often do you do it? So it's every 6 months until about 1.5 years, and then afterwards you can do it for about 1 to 3 years later on here. And this is the sort of algorithm. So where again the same thing I'm going to repeat. So you have echo here, the LVEF, and then you have these three categories here, and then you have the follow-up at later point, and the focus again to emphasize is the GLS, 3D, and diastolic function. So these are the main parameters to look at. So this is my last slide. So this is a statement, whatever it is the patient symptoms that matter to us. However, we can have three different approaches. You can agree with the GDMT, you can have your own perspective, you can have your own clinical experience, but it's important that the heart failure, even if it has improved, should the heart failure drugs be stopped? No. So this is as far as the heart failure with improved ejection fraction. Thank you.
Thank you very much indeed. My question in cases of diabetic cardiomyopathy, if your number of patients is the mid-range diabetic cardiomyopathy early stage, how much correlation, particularly glucose uptake, excitation constant coupling, and TP uptake, how much correlation with this structure and histological changes with the clinical symptom on basis of echo?
The diabetic group doesn't do well, so they don't fall into this category where they are likely to have improved ejection fraction. So they are the ones more likely to stay at the reduced ejection fraction. So that is very clear. So diabetics are a separate category. The coronary artery disease is another category where there's less likelihood of an improved ejection fraction take place. And all those mechanisms come into place where the myocyte doesn't really sort of recover and they sort of go into adverse remodeling.
Obesity also, there is another subset, particularly dyslipidemia altogether, obesity. Yeah. Some group of patients presented with heart failure, and eventually with the use of all the newer guideline-directed drug, enough improvement happened. Just one of my patients, 1 year before heart failure, 30%, and day before he started seeing the patient, the ejection was 65%. So how much possible by doing along with the drugs, these things?
The obese patients, usually more of them are there because of the metabolic syndrome. They are more likely to have heart failure with preserved ejection fraction. So that would be the one. But if they do have the recovered ejection fraction, as far as data is concerned, I don't recall the obesity sort of being as a group where they have looked at, so we still have to look at in the data on it. They have primarily looked at the age, younger age, they have looked at gender, they looked at women, and they've looked at these diseases and the markers, lower BNP, but obesity as a group, I don't really recall.
No, there is actually this patient is very astonishing also. body weight 115 kg, 30% ejection fraction, present to ventricular failure, and detailed follow-up period last 1.5 years. I seen the patient that is 65 ejection fraction and body weight is 68 now. So I have selected the cases and sent for publication to the journal. Very interesting observation to me as well.
Yes,
I want to get the explanation along with this. You know that is the case of EM, particularly diabetic, particularly in the obesity, LV derangement happened very commonly.
Yes. One of the other parameters is, as you saw in the studies, is the systolic BP also. The more they are controlled when coming to the obese patient, the more likelihood of the improved ejection fraction happening. So that could be one explanation here.
Thank you very much, excellent presentation. Next speaker, I can request him to introduce Dr. Achyut Sarkar.